Essentials of Cardiac Imaging, which is course MSE S31. So welcome, and thank you for getting up early in the morning to attend the course. We have 3 speakers, and even though my name is last over here, I'm first on the program, and I'm going to start first. So I have no financial disclosures. And I'm going to be talking on bypass grafts. So we usually, about 500,000 bypass grafts are performed per year in the United States. And the main indications for these are left main disease, triple vessel disease, 1 or 2 vessel disease involving the proximal LAD, and refractory symptoms. And the aim of the bypass grafts is to restore myocardial perfusion to ischemic territories, not only to improve symptoms, but more importantly, to improve the long-term survival. So why do we need to image the bypass grafts? These grafts develop disease early on in the post-op period or even a number of years later. So we need to assess what's happening to the grafts, particularly when the patients become symptomatic. And we also assess disease progression in the native non-grafted arteries, which can be as much as 40% at 10 years. Another reason to image these grafts is in the pre-op evaluation of redo cardiac valve surgery, aortic surgery, or redo CABG. And for these cases, we usually assess the graft patency, we assess the native coronary arteries, the proximity of the graft to the sternum, and the proximity of the cardiac chambers to the sternum, so that guides the surgeon to his surgical approach, whether it's going to be median sternotomy or a paramediastinal approach or something else. So the grafts are easier to image with CT because they are of a wider diameter, they are less affected by cardiac motion, and they have less calcified plaque than native coronary arteries. And in fact, the appropriateness criteria that came out in 2010, the second lot of these appropriateness criteria, which were revised, include bypass graft imaging as an appropriate indication for cardiac CT evaluation. When we look at accuracy of cardiac CT, we've been looking for patency of bypass grafts even with an older generation of scanners, and we can see that is this graft patent or not. If you're looking for that sort of a thing, the sensitivity and specificity is really high with the current generation of scanners. However, the distal anastomosis can remain challenging because of the size of the distal vessel, and it's not a dynamic sort of study. And this is another meta-analysis looking at 16 and 64 row scanners, and we can see high sensitivity, specificity, negative predictive value with a positive predictive value of 92. When we look at dual source CT, in this paper they were looking at not just the graft patency, but they were looking at distal runoff vessels, the grafted native coronaries, and the non-grafted vessels. And you can see that for the distal runoff, the sensitivity was 95%, but specificity, positive predictive value, and negative predictive value very high. For the grafted natives, excellent sensitivity, negative predictive value, and very good specificity and positive predictive values. However, for the non-grafted native coronaries, these numbers were not very good, particularly with the positive predictive value being lower at 83. So these authors concluded that non-invasive coronary angiography is useful in evaluating bypass graft patency in symptomatic patients. However, invasive coronary angiography is still required for assessment of distal runoff vessels and the native coronaries. So what about the technique? What is different about this when we compare it to just imaging the native coronary arteries? So the bypass grafts, if you have an op node, you can optimize your scan parameters. But if you do not have the op node, you want to make sure that you include the subclavian arteries, because the internal mammary arteries come off those. And you really want to look at that. And you want to go about 2 centimeters below the apex of the heart, so you cover the scan range to evaluate the bypass grafts. If you did have an op node and you knew that the patient had saphenous venous graft, you could basically bring this down, and that would reduce your radiation dose. At our institute, we use the timing bolus, but at some institutes, you may use smart prep. or bolus triggering, what we use is a timing bolus of 15 cc's at 5 cc's a second, followed by a saline chase with a region of interest in the aortic root at the level of the left main takeoff, and we generate a time curve. And what we do is we use peak plus 6 seconds to basically trigger our scan. And we've used two methods. We give 100 cc's because we're scanning a longer range in these patients, and we currently use method 2 where because we've got a large group of large patients. So what we do is the first 80 cc's are, we basically inject at 5 mils per second, and the next 20, it's a mixture of 40, 60 or 60, 40, depending on how large the patient is, at 5 mils per second, followed by a saline chase. And we uniformly get very good opacification of the coronary arteries. We use a collimation of 0.625 with a gantry rotation of 0.35, pitch of 0.221, and the KV is basically used depending on the patient size. We have a BMI chart, and we vary the KV and the MA, and even the injection protocol according to that chart. So when we're reading coronary artery scans, we have to basically have certain questions in mind. What is the clinical question that needs to be answered? Do we have a surgical note? Can we determine what the surgical anatomy is, because that can be very helpful? And do we have any other imaging like CAT, nuclear medicine tests, which may show, which could be abnormal or normal, and any prior CTs that the patient might have had, cardiac CTs. So when looking at the grafts, the ones that we commonly come across are the saphenous venous grafts and the internal mammary artery grafts, and it's predominantly the left internal mammary. We want to look at the proximal anastomosis, the distal anastomosis, the graft proper to see whether it's normal, whether it has any pathology or any complications, the distal runoff vessel, the course of the graft in relation to the sternum, and then the native non-grafted vessels. The axial images give us most of the information. They are not adulterated by any of these post-processing methods. So you really want to look at the axial images to see what you see, and then interrogate each graft separately using these methods depending on what workstation you're using. Now, I do not like using volume rendering imaging routinely on cardiac CT, but I find it extremely useful for bypass grafts. It really gives you a quick overview of what grafts you can see, where do they hook up to, and this is very useful even for the surgeons, or if the surgeons want to show the patient what their surgical anatomy is. So if the patient had 4 grafts, 2 got occluded, you can see the other 2. So I always start with the axial views, and I want to know whether the internal mammary arteries have been harvested. So here is the right internal mammary, here is the left internal mammary. You basically know that they are in their normal position, just lateral to the veins. So these internal mammary arteries have not been harvested for this patient's grafts. He has saphenous venous grafts that you can see down here, and one of the grafts here has got some stenosis in the proximal portion. The other graft has no contrast within it, and it's occluded, and we'll see this patient later, but I just wanted to show you the internal mammary arteries. So keeping that in mind, when we look at this patient and his internal mammary arteries going down, we see that the right internal mammary artery is in its normal location. The left has been dissected away from the parasternal region down into the mediastinum, and this has been harvested to basically anastomose to the distal LAD. So that way you know whether they have used the internal mammary artery for bypass grafts. This patient also has a saphenous venous graft. So here, when we're looking at these volume rendered images, this really beautifully depicts what the patient has had. So here's your native right coronary artery. Here is your saphenous venous graft to the PDA. And this patient also has had 2 other saphenous venous grafts here. And these are to the diagonal and obtuse marginal branch, a big obtuse marginal branch. This patient also has an internal mammary graft, the left internal mammary artery, but it's really a thread-like vessel. So this, I'll show you later other images of this, that this was an occluded graft. Oftentimes when the internal mammaries occlude, you don't see anything at all. It's gone. So looking at the different parts when we are evaluating these grafts, this is the proximal anastomosis. The saphenous venous graft usually attaches to the anterior wall of the aorta. So here's a proximal anastomosis, widely open, graft looks great. Here is the distal anastomosis. So you can see the graft, this is a saphenous venous graft, so big caliber attaching to a smaller caliber distal runoff vessel, and the distal anastomosis is patent. Here is what is called a sequential or jump graft. This graft here has some calcification in the walls. It has a side-to-side anastomosis with a diagonal vessel, and then an end-to-side anastomosis with the LAD. So sometimes you have a bypass graft that basically supplies two territories. So the conduits that are normally used are the internal mammary arteries, of which the left is most commonly used, and saphenous venous grafts, and these others are very rarely used. So the vessel of choice for revascularization of the LAD is the lima. It's closest to the LAD. It has no vasa vasorum in the vessel wall, so it doesn't develop intimal hyperplasia, and it's less atherogenic. I showed you a vessel that was doing a side-to-side or end-to-side anastomosis. Here you have an in-situ graft, and you want to look at the subclavian proximal to the lima when you're evaluating them, because if there is tight stenosis there, then it will hamper the graft. So here is the lima to the LAD. Occasionally the lima can be used as a sequential graft. And here you're seeing a curve reformat of a patent lima, a few surgical clips along the way, but you see it very beautifully, widely patent, anastomosing to the distal LAD. The rima also can be used as an in-situ graft, similar to the LAD. It usually goes to the right coronary artery, but when both the rima and lima are used, then the rima often goes to the right coronary artery and the lima to the left side at LAD or diagonal. However, when both internal mammary arteries are used for the left side, the rima usually is anastomosed to the LAD, and the lima on the lateral wall circumflex OMs, ramus intermedius. And sometimes the rima is anastomosed to the circumflex, where it passes through the transverse sinus. And very often it can be used as a free graft, like you do with the saphenous venous graft with a proximal anastomosis on the ascending thoracic aorta. So here is a rima that's widely patent. This patient did have a lima that was occluded, and so they did this rima to the LAD. And here is a rima used as a free graft, so widely patent. What you see is the proximal anastomosis to the ascending thoracic aorta, and here is its distal anastomosis in fact, this was not the patient who had occluded lima, because the lima goes to the LAD and the rima goes to a diagonal branch. But I have seen this happen in patients where when the lima is occluded, they can use a rima branch. The downside of this in patients that are diabetic is that when you're using both internal mammary arteries, diabetic patients can sometimes develop necrosis of the sternum. So they don't usually like using both internal mammary arteries. So the internal mammaries have a low rate of disease. The occlusion rate in the first year is less than 5%, and more than 80% are patent at 10 years. This is that volume rendered image that I showed you, the lima, very thread-like. What you're seeing is the contrast here in the vessel is not very good, and it's very, very thin, but you're seeing some contrast more proximally near the subclavian, where the takeoff is of the vessel, and this is just retrograde flow, and the LAD is filling via collaterals. Moving on to saphenous venous grafts, these are of larger caliber. There's absence of surgical clips along the course, and they can be used as a sequential graft like I showed you. The long-term patency for these is poor when compared to the internal mammary arteries, 50% at 10 years. So they can be commonly used for revascularization of any of the major branches. And usually they're anastomosed, to the anterior wall of the aorta. For the right side, it's to the right, and left-sided vessels here on the left. So here you've got this one going to the PDA and these two going to the left-sided vessels. So here is the native right coronary artery. This is the patent saphenous venous graft to the PDA, widely patent, a few foci of calcification. Here are those two branches, the saphenous venous grafts to OM1 and OM2, widely patent grafts. So saphenous venous grafts are easy to access and harvest, and they're less prone to spasm, but they do develop intimal hyperplasia, and they're more prone to developing atherosclerosis, and they have a low patency rate over time. Radial grafts are very rarely used. This was given to me by Charlie White. These you usually harvest from the non-dominant arm. There are lots of surgical clips along the course, so sometimes you can get artifact, and also they're more prone to spasm. And then this is one where it's a complex procedure using the gastroepiploic artery. You have a thoracoabdominal approach, and this vessel usually is used to anastomose to the PDA, and I've never come across it in personal life in the last 10 years. So saphenous venous grafts, 12% of these occlude acutely post-op, and they can also be prone to spasm or kinking. And here is a patient who came to us from an outside institute, had a PE scan to rule out PE because of chest pain, and they didn't have any pulmonary emboli, but on their PE scan, which were thick sections, you could see a tubular sort of structure, and it was a graft. And they did this bypass graft CT evaluation, and what we saw was an acutely thrombosed graft dilated with thrombus, and this patient basically had just suddenly thrombosed his saphenous venous graft. Late complications, we come across these often: stenosis, complete occlusion, aneurysms, pseudoaneurysms, and then progression of atherosclerosis in the native coronary arteries. Here is a saphenous venous graft to the PDA, and I want you to look at the proximal anastomosis. These are the orthogonal cross-sectional views. There is some plaque, which may be difficult to see up here. I'll show a close-up of that in a minute, but they've got circumferential non-calcified plaque at that proximal anastomosis, causing about 45 to 50%, less than 50% stenosis. So this patient underwent cath, and there's very good correlation here. You see the non-calcified plaque at that proximal anastomosis, and here you can see the narrowing. It's not significant. And this graft was very close to the sternum as well, which was dictated in the report. Here is another patient at the proximal anastomosis. You've got mixed plaque, calcified and non-calcified, causing about 50% stenosis, as seen on these orthogonal cross-sectional views. And here is a patient who's got a saphenous venous graft to the LAD, and this is the native LAD occluded here, but when we look at the graft itself, it's got some mixed plaque in the proximal portion of the graft, but when we come to the distal anastomosis, there's a very tight stenosis, a critical stenosis, and the distal runoff vessel has got a significant amount of plaque as well. So sometimes, like, even though the distal anastomosis may not look that narrow, the distal anastomosis may not be functioning as well, and at cath, you sometimes have flow not going through the vessel, but going retrogradely back and forth before it goes into the vessel. So we do not see that with CT. So here is another patient. I want to show you a saphenous venous graft in a patient who had chest pain. So scrolling down to the anterior wall of the ascending thoracic aorta, we see this saphenous venous graft coming off if you follow it. So it's got some plaque here at the proximal anastomosis, but let's keep following it. So it's coming behind the sternum. Here's your pericardium, very close to the sternum. Watch it closely. Look at the caliber of the vessel. Look at it there. So this gray stuff, is this non-calcified plaque causing such narrowing of the artery, of the graft, or what is this? And then it's a little bit dilated and then normal caliber as it's going to the LAD. So when we look at this, you've got some disease proximally, not significant, but here you've got a critical stenosis, and you do not see plaque so widening up the vessel. So what happened in this patient was, usually you have some retrosternal fluid and some postoperative changes. Perhaps this one became a little inflammatory, like you would with a phlegmon or things like that you get elsewhere, and then it led to narrowing of that vessel there. And I've come across 2 or 3 cases like this, not many, but it's important to look for that as well. You can see that this is not non-calcified plaque. It's a larger area of abnormality in the region of stenosis. And here it is, where you see it on these volume rendered images as well. So it would give a good idea to the surgeons if they were to go in again and regraft this patient. This was another image that was given to me by Charlie White. In the perioperative period, the graft looks widely patent, and then over time, you've got like thin rim here, edge of non-calcification, like grayish stuff, which was neointimal hyperplasia. I really haven't come, even though I've seen it in many papers and things, I personally have not come across it at all. Here was that patient that I initially showed you who had one graft that was patent and the other one that wasn't. And this is a chronically thrombosed saphenous venous graft to the obtuse marginal. And you're seeing calcification in the graft, no contrast. The other graft next to it had calcified walls, but it was patent. And then the distal runoff vessel fills via collaterals. Here is one where you're seeing the proximal anastomosis, and then you're just seeing a bit of gray, and then I couldn't follow it much at all. And this is called ghosting, and where a graft was previously patent. And sometimes you may come across this, which is called a nubbin. Here you're seeing a dilatation at the proximal anastomosis and a little bit of ectatic graft, but here it's basically completely occluded. So this is the nubbin sign. Saphenous venous grafts, when they develop stenosis, you can stent them. Here are 2 stents in this SVG graft to the PDA, and both stents are patent. So in this patient who had chest pain, they wanted to evaluate whether the stent was patent. The patient's got a little bit of non-calcified proximally, stent widely patent, critical stenosis just distal to the stent. So what they did in this patient was they put another stent to basically treat that area of critical stenosis, and the patient did well. Here is one where you've got a saphenous venous graft with a stent. You can see some contrast in the proximal stent and then an abrupt cutoff, no vessel distal to it. So this was completely occluded. There. And here you can see like aneurysmal dilatation at the proximal anastomosis in these SVG grafts. Here is a patient. This was an aortic CT that I was reading, and this is aortic dissection in this patient, so it was follow-up for aortic dissection. This patient had a diffusely aneurysmal saphenous venous graft, which had a significant amount of thrombus. You can see it better here. Here's the graft. You've got a significant component of thrombus within that graft. And here is one, another aortic CT that if you didn't look at the grafts in the coronaries, you may miss, but this patient had a saphenous venous graft, a single graft, big aneurysm with a significant amount of thrombus, and when you're looking at it, it was anastomosing to the obtuse marginal, and that distal anastomosis here was like the stenosis at the distal anastomosis. So if they did a cath on this patient, they won't see the thrombus bit, but they would see the area that we see filled with contrast. Unfortunately, this patient did not have any other suitable vessels where they could do they could graft this patient again, redo bypass grafts. So we are following this patient, and this graft is slowly increasing in size. So here is his cath. Here is that aneurysm. Here is the tight stenosis that I showed you on CT. So it was a very good correlation with this cath. And here, what happens when these aneurysms or pseudoaneurysms increase in size? So here is a patient. This was again a PECT, not a dedicated coronary. Pulmonary arteries were fine. Here's one saphenous venous graft with an aneurysm. But look at this anteriorly, a lot of stranding in the mediastinal fat. Here you have an saphenous venous graft coming off, calcified, ectatic, aneurysmal, a lot of stuff going on here. This graft basically here had ruptured, and there was a humongous amount of mediastinal hematoma compressing the right ventricle and the right atrium. You can see here as well, and there was even hematoma basically in the hemopericardium in this patient. So this sort of a thing, this patient did not survive. So it's important to look for such complications even on other studies. Don't forget to look at the proximity of the graft to the sternum, and we oftentimes, even on normal CTs, I mention it if it is. So the limitations of CT are that the distal anastomosis sometimes can be difficult to evaluate. Even though we see that it's patent, it may at cath be compromised, and we don't see the dynamic imaging. But if your quality of images is reasonably good, with cases where we have stenosis like I showed you, we can make a reasonably accurate diagnosis. So the direction of flow at cath is difficult to, we don't see that at CT, and which can tell us that the graft may be in jeopardy. And the native coronary arteries in these patients are really difficult to evaluate. They are heavily calcified. These patients have a heavy atherosclerotic burden, and so oftentimes those, if they need to evaluate those cath would be the best thing to do. But for the grafts themselves, if they've got multiple grafts, CT is excellent. I also have had patients where, as an inpatient, they've had bypass grafts, say 2 days or 4 days ago, the ejection fraction suddenly dropped. The patient's not a good candidate for cath. They want us to look at the CT, to look at the grafts on CT, and even if the patient's heart rate, if it's difficult to control, we can see grafts reasonably well. And I had one such patient who had 4 bypass grafts, all of them occluded within 3 days. So we can help them in basically making diagnosis and further management of these patients. So CT exquisitely depicts bypass graft surgical anatomy. As I've shown, it's excellent at evaluating graft patency, and we can really see early and late complications really well with CT, and we can communicate this very well to our referring physicians and surgeons, even with the images. I thank you for your attention. The next speaker is John Ho, and he's from Singapore, and he's going to basically take you over to the next half session, 30 minutes of coronary stenosis imaging.
These are my financial disclosures. Okay, this morning I'm going to talk to you about quantification of coronary stenosis by coronary CTA, accuracy, difficulties, and functional significance. First, I'm going to talk about detection of coronary stenosis, and then talk about quantification of coronary stenosis and how you do this, and why it's not the same as detection of coronary stenosis. And then in the final half of the talk, I'm going to talk about the functional significance of coronary stenosis when you see it on your coronary CTA. What is the correlation of coronary stenosis with myocardial ischemia? I think you're all pretty familiar that the accuracy of coronary CTA compared to cath or QCA is very well documented. There have been many single-center studies, mainly on 64 slide scanners, 4 multi-center trials, and 3 meta-analyses. And all these reported studies use a threshold of 50% limited luminal narrowing to define clinically significant stenosis and to assess diagnostic accuracy. And so coronary CTA now is established as the best non-invasive test for diagnosis and detection of coronary stenosis compared to other non-invasive tests such as exercise treadmill, stress echo, stress spec, etc. because of its, as you all know, the high negative predictive value and it has the highest sensitivity of all the non-invasive tests. It's also the best non-invasive test to rule out and exclude significant stenosis of more than 50% because of this high sensitivity and high negative predictive value. Now, your referring physicians have some expectations of your coronary CTA report. Firstly, they expect high accuracy because of all the previous reported studies talking about the high sensitivity, specificity, and negative predictive value. However, they are often not aware about the relatively low positive predictive value of CT, which is usually around 80%, which is usually due to calcifications and motion and results in false positives or overestimation of stenosis severity. So at the same time, if you're reading a scan, you are not allowed to miss or underestimate a stenosis because of the high negative predictive values reported. Your referring physicians may also not be aware of the limitations of some of these studies that I've just talked about. Almost all studies use a binary cutoff of more than 50% as positive. They had unlimited time to analyze the images, used consensus of 2 expert readers, excluded patients with severe calcifications in some studies, and uninterpretable segments, for example, due to motion, were often excluded when they should have been counted as positive for stenosis. So all these factors are often obviously not realistic in clinical practice, and so the results of most clinical centers may not be as good as published in the literature, which all these were usually done in academic centers with expert readers. At the same time, your referring physicians want quantification of degree of stenosis and expect accurate grading of the degree of stenosis to guide further clinical management, and they may not be aware of the difference between the accuracy of detection and quantification of coronary stenosis. How do you quantify coronary stenosis when reporting? Usually we use percent diameter stenosis for detection and assessment of coronary stenosis and compare it, for example, to QCA, which is considered the gold standard. And the reason why we usually use percent diameter stenosis is because it's similar to cath. So there are three ways to assess your images for quantification of coronary stenosis. One is visual estimation or eyeballing. You can do direct measurement of stenosis on cross-sectional views or long-axis views, and usually you can do this manually, and can be considered semi-quantitative assessment. Or you can use the automated vessel analysis software, which is available on your vendor's workstation, and some people call this QCCTA. Now, if you're going to do visual estimation, for example, what is the degree of stenosis in the distal left main in this case? Do you think it's more than 50%? Just to refresh your memory as to the anatomy, the distal left main extends to here, and there's disease here in the ostium of the proximal LAD. So how many of you would think there is more than 50% stenosis here? Here's the cath, and you can see that's actually minimal stenosis. And I just want to show you there is positive remodeling here in the distal left main. You can see it's slightly dilated. So if you're going to do visual assessment, make sure you use a healthy or normal proximal distal reference site for comparison as your reference site. Do not overestimate, which you tend to do if there's positive remodeling at the site of the stenosis. And you need to always compare the contrast field lumen containing the stenotic segment to the normal contrast field lumen of the artery, either proximal or distal to the lesion. In other words, you compare lumen to lumen. If stenosis is present at the ostium of a coronary artery, then you try and use the adjacent disease-free distal reference vessel point. And for bifurcation lesions, we try to use a proximal reference vessel point. And once you've done that, you can calculate the percent diameter stenosis by using this formula: reference diameter minus MLD divided by reference diameter times 100. There is, of course, alternative methods. An alternative reference site is you can, at the level of the stenosis, the normal luminal diameter is estimated and used as a reference. And this is usually what is done in QCA, but not done on your workstation. So obviously, the percent of stenosis may differ according to the location of the reference or the type of reference site you are using. Victor Ching and his group in LA published this paper a few years ago talking about using visual analysis using a 5-point grading system for stenosis severity. They used a 5-point grading system analyzed by visual analysis and by manual semi-quantitative analysis and compared with QCA. So here you see grade 0, no disease, grade 1, 1 to 24%, grade 2, 24 to 49, grade 3, 50 to 69%, etc. And they found that visual analysis had significant correlation with QCA and was no worse than manual measurements. But they also found there are wide limits of agreement of more than 20%, so you basically cannot accurately grade stenosis severity. So their conclusion was that you should adopt a visually based, multi-tiered grading approach to evaluate coronary stenosis because it's pretty similar to manual measurements, and that at the same time, they concluded from their study a 49% lesion on coronary CTA can be considered virtually exclusive of a 70% stenosis at cath. As I said, you can also do manual semi-quantitative quantification coronary stenosis. The first method is use cross-sectional images created perpendicular to the center line of the vessel, similar to IVUS. This is like a double oblique. Then you do MPR manually measured measurements and use the measurement calipers on your workstation, and you measure the minimal lumen diameter, which happens to be this one and not this one. And you assess MLD at the stenosis and compare it with a normal reference site, either just proximal or distal. The question is, should you use thin slice 0.5 or up to 1 mm MPR images or thick slice 3 mm MIPS to read your scans? Because some workstations automatically generate mm MIPS. MIPS mean maximum intensity projection images, which may obscure stenoses because the pixels containing high density contrast are retained, while low density plaque pixels are discarded. So the resulting MIP image may underestimate stenosis. So if you're going to use MIPS, don't use MIPS that are too thick because you're going to underestimate stenosis. And they should never be thicker than the vessel size, preferably 3 to 4 mm, maximum 5 mm for the left main. And my preference is actually you should use thin slice MPRs rather than thick slice MIPS to read your images. You can also create long axis views of the stenoses, which simulates a cat-like view. But to do this, of course, you have to create 3 to 5 mm thick slab MIPS parallel to the long axis, and then you can compare the luminal diameter at stenosis with the normal reference site. Surprisingly, there have been actually relatively few papers on quantification of stenosis done, and most of them were done on old scanners. This is one done on 64 slice scan, and you can see that the standard deviation or 90 to 95% confidence interval is approximately plus or minus 20% to 30%. And in fact, Gilrath back in 2005, which is a long time ago, concluded that CT can predict QCA results within 25% with about 90% probability. So have we improved with all the new scanners? This is a paper on 256 scanners and quantification, and you can see the same thing. The two standard deviations plus or minus 20%. So there's no real improvement of quantification of coronary stenosis using 256 scanners because the spatial resolution of all the new scanners from all the 4 vendors has not really improved because the detector widths from the scanners have not changed since 64 slice. They're 0.5, 0.6, or 0.625. So when you're reporting, you should really use the SCC guidelines for your report. The SCCT guidelines does have a quantitative recommended stenosis grading system of 5 points, similar to what Dr. Ching first published. And this is in 20 to 25% increments. And they have an optional quantitative stenosis grading system, which is in 30 to 40% increments. And I draw your attention to the moderate category. Here for the 5 point, it's 50 to 69%, and for the 4 point, it's 40 to 69%. These are often called the intermediate coronary stenoses and often give us the most trouble, which I will show you in a few minutes. So obviously, further management of the patient is going to be based on your report, but at the same time also based on the patient's symptoms. Generally, most centers will use 50% diameter stenosis as considered significant or as the cutoff for management. So if you report your CT as 50 to 70%, if the patient is symptomatic with chest pain, etc., they will usually go for some sort of stress testing or ischemic testing. And if they get to the cath lab and there's still some doubt, then they may end up getting FFR or an IVUS study. But if your CT shows that the stenosis is more than 70% and the patient is symptomatic, then usually they will go straight to the cath lab. If the patient's asymptomatic, then often they will have ischemic imaging as well. CT does tend to overestimate the degree of stenosis compared with CAS and QCA, and the main reason is because of the difference in the spatial resolution between CT and CAT. So, as I mentioned earlier, the best detector width is 0.5 for a CT, which is 9 line pairs a millimeter, and for a CAT, that's 50 line pairs, so there's a difference of 5 times. So actually, for a 2 mm vessel, you only have 4 voxels or pixels available for analysis. So you can only report a stenosis as 0, 25, 50, 75%. You should not generate a report and say there's a 43 or 68% stenosis because you don't have that resolution. In fact, to differentiate a 10 to 20% coronary stenosis will require isotropic spatial resolution of at least 0.3 mm. And the vendors haven't produced detectors of that diameter yet, or that resolution yet. Now, what about other ways of quantifying coronary stenosis aside from diameter stenosis? Minimal luminal diameter, MLD, is rarely used. Some people use it. Typically, it's measured in the long axis view, as in cath, but it's actually best measured in cross-sectional images. If you're going to do this, then most people use cath data, QCA data, and say that if it's less than 3 mm for left main, it's significant. Less than 1.8 mm for, say, the proximal LAD, it's significant. But there are two other measures, areas stenosis and minimal luminal area, which I want to concentrate a bit on. Because on your workstation, you always have your full set of data, and you should try and use cross-sectional images to assess for coronary stenosis as a supplementary tool. It can only be performed on true cross-sectional vessels views using double oblique MPRs, and similar to intravascular ultrasound. You can measure it either manually or use QCC, the automated software, and you can measure two parameters, MLA, millimeter squared, or area stenosis. I draw your attention to this chart. A diameter stenosis corresponds to an area stenosis of 75%, and a diameter stenosis of 75% corresponds to 94%. These are easy numbers for you to remember, but remember this relationship only works if the stenosis is completely concentric, and often disease is eccentric. Harvey Heck from Lenox Hill in New York published this paper a few years ago, and he still advocates using MLA, millimeter squared, to assess for coronary stenosis similar to IVUS. He suggests you use the automated software on your workstation because reduction in cross-sectional area correlates better than reduction of diameter for flow limitation or assessment of hemodynamic effect of stenosis. And these are the cut points that he recommends, which are easy to memorize. Less than 4 for proximal vessels, less than 6 for left main. This is, of course, based on IVUS data. Because IVUS data determine cutoffs for cross-section areas are well known to correlate closely with hemodynamically significant stenosis. Usually IVUS is used at the time of PCI to plan appropriateness and to plan what type of stent to use and whether the stent has been placed properly. So in this chart from this paper, he recommends that if there's a stenosis on CT of 50 or 75%, or the MLA is less than 6 mm squared in the left main, less than 4, then these patients, assuming they're symptomatic, need to go to the cath lab. And if there's some element of doubt in the cath lab, then of course they will go on to IVUS or FFR. FFR, just to refresh your memory, is fractional flow reserve. It's performed at the time of cath, used to measure the intracoronary pressure using a pressure wire to determine severity of ischemia, and usually intracoronary adenosine is injected to get maximum flow, and then the FFR is calculated. You just need to know that FFR less than 0.80 is considered abnormal and considered hemodynamically significant, although some people use 0.75 as the cutoff. FFR is considered the only method and the gold standard to determine lesion and vessel-specific ischemia. And FFR-guided PCI has also prognostic value because it's been shown to improve event-free survival in patients, 28% fewer MACE events compared to those who had cath-guided PCI. At the same time, although I mentioned IVUS is useful for determining ischemia, at the moment, there is no clear-cut agreement on optimal cutoff for IVUS if IVUS-derived MLA mm squared is used for predicting FFR less than 0.80. Recent papers have suggested that actually left main less than 4.5 millimeters squared or LAD less than 2.5, rather than those cut points I mentioned, should perhaps be used now. So there is some controversy. At the same time, area stenosis is typically not used as an IVUS measurement for ischemia. Usually it's millimeters squared. Although some reports say that if the area stenosis is more than 70%, remember I said earlier this corresponds to diameter stenosis of only 50%. This corresponds to an FFR of less than 0.75 with high sensitivity and high specificity. This is because probably the disease is eccentric. So generally what the cardiologists are doing is they do perform FFR at the time of PCI to decide whether PCI is necessary, and then use IVUS to determine how the PCI should perform, what size stent, how long, etc., and check the position of the stent. Now, what about using automated software? Previously less accurate, now improved and more reproducible. As you all know, you can just do centerline extraction, lumen segmentation, and you can get all these 4 measurements out pretty easily. And using current CT technology and software, a standardized post-processing method quantitative measurements of stenosis is considered fairly reproducible, but of course can only be used in high quality images, and also we can use this for coronary plaque analysis, which I'm not going to talk about today. So it's been suggested that actually MLA, millimeters squared, may be the best approach because this is a 2D area-based measurement, better than 1D, less affected by blooming, less affected by viewing angle because you have to get a cross-sectional image. It's more reproducible because there's no reference site needed for MLD assessment. So how good is CT versus IVUS for estimation of coronary stenosis? In this paper that was just published a couple of months ago in JCCT, in this meta-analysis of 42 studies, compared with IVUS, CT seems to be highly accurate with no significant differences found for estimation of luminal area, MLA, millimeters squared, or percentage of area stenosis, and even for plaque volumes, plaque area, and detection of plaque. This is in spite of concerns about the limited spatial resolution of CT compared to IVUS. Maybe the spatial resolution of CT is good enough for this sort of analysis. And that using automated vessel and stenosis measurement software appears promising in the few limited studies that have been performed. This is one of my patients, and if you just eyeball this in the proximal LAD, I think most of you would say there's less than 50% stenosis. And if you do the software calculations, you can see diameter stenosis 56%, which sort of corresponds to the area percent stenosis of 78%, although it's overestimated because the disease is fairly concentric. But when you do the MLA measurement, it comes at 1.8 millimeters squared. Remember, less than 4 is considered significant or severe. So how accurate is this? This is obviously overestimated. Are there any new methods for assessing or quantifying coronary stenosis? This paper was just published in Radiology 2 weeks ago online by Dr. Lee from Shanghai, and it's a very, very interesting paper. Based on Poisson's equation, using the ratio of the lesion length to the fourth power of the MLD fourth, they say that you can differentiate between hemodynamically significant and non-significant lesions and then correlate it with FFR. So for example, in this patient, the lesion length and the MLD to the fourth ratio is 4.4, which is considered hemodynamically significant, and you can see the FFR is just abnormal at 0.79. So their results said that this yields high diagnostic accuracy in the diagnosis of hemodynamically significant stenosis. So I think this is very interesting. We can all go home and try this, see whether it works. So why do we need to know the functional hemodynamic significance of a stenosis? Because what defines PCI success is not just the technical success of restoring flow or symptomatic success, relieving the patient's severe angina, but functional improvement, for example, improvement in LV ejection fraction, and survival improvement. This is the most important. That means you have to show improved survival time with no major adverse effects. So revascularization should only be done to improve severe angina and should not be performed if there's no likely improvement in long-term cardiac event rates for survival. So should ischemia guide revascularization decisions? And the answer is basically selecting patients for revascularization on the basis of the presence of ischemia seems to be appropriate. In fact, so appropriate that the ACC guidelines, for example, in 211 for PCI, for example, for chest pain, PCI to improve symptoms is reasonable in patients with one or more significant stenosis of more than 70% coronary artery stenosis associated with ischemia and unacceptable angina in spite of optimal medical therapy. PCI, for example, should not be performed with the sole intent to improve survival in patients with stable ischemic heart disease with one or more coronary stenosis that are not anatomically or functionally significant. That means less than 70% diameter stenosis for non-left main disease, FFR more than 0.8, no or only mild ischemia on non-invasive testing. Okay, that's the recommendation. So how do we assess patients for presence of myocardial ischemia? Of course, there's a wide range of tools. There's stress echo, nuclear medicine or SPECT, PET rubidium, cardiac MR, FFR, which I've mentioned. What about cardiac CT? Well, actually, what is the functional significance of a more than 50% stenosis detected by CT? Many studies have been done over the years showing that a more than 50% coronary stenosis seen on CT is a poor predictor of reversible ischemia when compared with SPECT or nuclear medicine imaging. And prediction of ischemia by CT is limited. Essentially, it's very easy to remember. If the CT shows less than 50% stenosis, usually the nuclear medicine study is normal. If the CT shows more than 50% stenosis, you get an abnormal nuke in approximately half your patients. This is probably related to overestimation of stenosis by CT. And all these studies show that basically sensitivity and negative predictive value of CT to detect ischemia is high, but specificity and positive predictive value is very low. But if you use a criterion of more than 70%, this may be a superior standard for hemodynamic significance for stenosis, as the positive predictive value is higher. So in fact, there have been two relatively recent papers that use 70% as the cutoff. And in this study looking at SPECT and CT, the presence of a more than 70% stenosis by CT was strongly associated with ischemia, with an odds ratio of 3.5. And in this other study done by a group from Taiwan, using 64-slice CT, a cutoff more than 70% diameter narrowing is a strong predictor of ischemia. So why do most of us still use more than 50% stenosis as cutoff for reporting significant stenosis on a CT requiring further evaluation? I think that's because based on all the previous reports that use 50% as the binary cutoff, the SCCT guidelines also recommend using the 5-point grading system where the moderate stenosis is 50 to 69%, and the optional grading system is this 4-point system from 40% to 69%. But at the same time, I think the main reason is that by using a threshold of more than 50% luminal narrowing or equal to, this decreases the likelihood of failing to identify patients in whom a cath is required. So I've shown you that more than 50% stenosis is a poor predictor of ischemia, but there are new or novel techniques available. And I'm just going to talk about them briefly. Because coronary artery enhancement contains information related to coronary flow, this information that can be obtained includes contrast enhancement differences, which you can see visually. I think all of you have seen subtotal occlusions and severe stenosis, where you can absolutely see a difference in the density. Or you can measure gradients such as corrected coronary opacification, transluminal attenuation gradients, and a new method called TAFI. But I don't have time to discuss this today. And there's, of course, computational fluid dynamics allowing FFR estimation by CT, or some people call that CT FFR. As I said, this uses computational fluid dynamics algorithms to process the data from your scan and calculate coronary pressure and flow. It requires a supercomputer and data to be sent to a single commercial site, and it's not cheap, and it takes several hours of post-processing. But it has been tested in 3 prospective multi-center studies against FFR as a standard, and the results are very promising, and the latest was just presented in October at TCT. So here's an example, for example, from JAMA from Dr. Min. You can see an intermediate stenosis. If you eyeball that, is at 60% maybe. But when you do the CT FFR, the FFR is obviously abnormal, 0.62 lesion-specific ischemia, which correlates with the cath, or the FFR obtained at the time of cath. What about CT myocardial perfusion? Well, you can do this as rest or stress scans, or stress followed by rest using pharmacological stress agents such as adenosine or regadenoson. Can be performed on 64-slice scanners, easier with the newer scanners such as the dual source, etc. You can do dual energy studies, and you can do optional delayed scans to look at myocardial viability. However, the scans are difficult to read because artifacts are very common from motion, beam hardening, and band artifacts. But at the same time, there's possibility of quantification of myocardial flow, for example, using something called a transmural perfusion ratio. So what are the results? Well, there have been several single-center studies have already validated CT perfusion, and this compares favorably with cath and FFR, but CTP is prone to high rate of false positive results. There have been 2 multi-center studies completed. One, the CORE-E trial, which was just published online on November the 18th, showing that the combination of CT and CTP correctly identifies patients with flow limiting more than 50% stenosis cath, causing a perfusion defect at SPECT. And this paper that was presented at SCCT earlier this year, which was a multi-center, multi-vendor trial, also had pretty good detection rates of ischemia using CTP. So in conclusion, You should use percent diameter stenosis to report coronary stenosis. Use visual analysis as your main method, but remember supplementary tools that can be useful include manual, semi-quantitative, or automated assessment of mm squared in cross-section. Area stenosis percent is less useful. Do not rely only on the automated software in your workstation because it can lead to overestimation of stenosis. Quantification of stenosis is plus or minus 20 to 25%. So the result for more than 50% stenosis reported on your CT could be 70% at cath and a PCI is needed, or it could be 40% and no PCI is needed. But obviously the patient has disease. But if the result on your CT is less than 50%, I think we can be pretty confident there is no stenosis present of more than 70% at cath. So if you see a stenosis of more than 70% reported in cath, there's very likely significant stenosis that is hemodynamically significant, and most of these patients, as I said, will go straight to the cath lab, especially if they're symptomatic. The criteria of using 70% or more stenosis is a superior standard for hemodynamic significance and is used in the cath lab to guide decisions regarding PCI. So the question is, should we use more than 70% diameter stenosis as the new standard for reporting of CT for significant stenosis rather than what we've been using all along? I don't really know, but this is just a question to pose to you. The functional significance of intermediate stenoses, that means 50 to 70% on CT, is unknown. And we await further work on novel methods, which I mentioned, such as transperfusion ratios, CT, FFR, CTP, etc., to improve prediction of myocardial ischemia by CTA. Thank you very much.
Morning, everybody. My name's Ruth Lim. I'm from the Austin Hospital in Melbourne. I'm just going to quickly switch over to my computer. Okay, looks like we're ready to go. So we're switching gear now. I'm going to talk a little bit about cardiac masses. And just a disclosure, I will be talking about contrast use in cardiac MRI, which is off-label, and I have no financial disclosures. So in the next half an hour, what we're going to talk about is begin with the pros and cons of CT and MR, take a look at some technical considerations, then we'll take a look at some mass mimics and also some masses, beginning with pseudotumours, that is the non-neoplastic masses, and finally neoplastic masses. Now I've included a link here to a handout, and that just includes a little bit more information than I can give you in half an hour. It has a few extra cases as well. It's a lot to copy down, so it's also on the next slide. Cross-sectional imaging is really important for the workup of the cardiac mass. Clearly it's not an easy place to get to with a biopsy needle. And most masses are found at echocardiography, either found or suspected, and we can perform MR, CT, and in certain circumstances also nuclear medicine testing for further evaluation. So our first question to answer is whether there truly is a mass. Once we're sure there is a mass, we want to characterise that mass further. Pseudotumours are the most common mass we're going to encounter in clinical practice. And primary cardiac tumours are pretty rare, so they occur in less than 0.25% of autopsy series. The more common tumour we're going to see is metastasis. So let's take a look now at cardiac CT. So everybody's aware of the pros of cardiac CT. It's very fast, it's readily available. It has that large field of view coverage that enables us to also assess the extracardiac structures. It has high spatial resolution and it's sensitive for calcification as well as fat, which is important in mass assessment. On the downside, it has relatively lower temporal resolution than echo and MRI, although with these newer generation CTs, the dual source CT, the 256-320 detector CT, that gap is now narrowing. Ionizing radiation certainly is a concern. Again, it's lower with newer CTs where we can perform single heartbeat imaging. And the downside of CT really for mass characterization is its limited soft tissue information. We'll compare that to MR, where soft tissue contrast is its major strength. There's no ionizing radiation. We have good temporal resolution, and those two factors combined mean that we can get a very good functional assessment. We can assess mass mobility and effect on the heart as well. On the downsides, we know that MR can be technically challenging. Even in experienced hands, it's going to take 45 to 60 minutes for a full mass protocol to be performed. Calcification is essentially invisible using our standard MR sequences, and there are safety issues. So in patients who have older pacemakers or defibrillators, then MR is a safety concern. Having said that though, because of the excellent soft tissue contrast, MR is really our primary imaging technique when we want to evaluate a mass further. So let's talk now a little bit about performing the imaging. For CT, generally we're going to do a full chest coverage, and that's important particularly if we're concerned about malignancy at all. And CT is a good option to consider in the obese patient, somebody who's claustrophobic, or somebody who's unwell and unable to lie still for too long. We want to use ECG gating for cardiac mass evaluation, and we can choose prospective gating at a lower radiation dose. It will tend to give us more of a simply anatomic assessment. Or we can do retrospectively gated imaging and reconstruct images at different phases of the cardiac cycle to get more of that dynamic assessment. Contrast timing and a rate is going to depend on what we're interested in. So if we want to evaluate the coronary arteries in a pre-surgical context, then we'll do similar parameters to what you've seen on the previous talks, a high injection rate, an arterial phase scan. If we want more myocardial phase enhancement, we might scan a little bit later and use a slightly slower injection rate. And now we can acquire very thin collimation, thin slice images, and this enables us to reconstruct the images in any plane, which is really important in mass assessment. So this slide just shows the importance of ECG gating. So we've got this image on the left where we can see blurriness of all the margins, so very poor interface of tissues, and this is really not what we want for mass evaluation. Moving to MR, so beyond our general setup and localizers, I would advocate supervision by either a radiologist or a cardiologist. Often with mass imaging, we're going off the standard planes, and it's just helpful to have somebody who has some knowledge of masses to tailor the examination. So there's many ways of performing a mass protocol. Generally, we want some kind of screening sequence that enables us to cover the whole heart and evaluate the location of the mass before going on to more detailed assessment. So in my experience, gated bright blood CNA imaging, usually a balanced steady state free precession sequence, or if there are issues with magnetic field homogeneity, we can do a spoiled gradient echo sequence, is useful for that initial screening sequence. So what we want to do is two orthogonal planes, so multiple slices to cover the whole heart with no gap between those slices. Now if we do this screening sequence and we don't see a mass, then we're essentially done. So that's the end of the mass protocol, and it's very quick. If, however, we do find a mass, then we want to go on and perform a multiparametric assessment. So we have our CNA imaging first, and this is going to enable us to assess the mobility of the mass and relationship to adjacent structures. Then we go on and do our black blood T1 and T2 weighted imaging. Generally, we're going to apply some fat suppression to the T2 weighted imaging just to help the pathology stand out a little bit more. Then we're going to perform our post-contrast imaging, and we can do first pass perfusion imaging, and this helps us to assess early enhancement of the mass. Again, we have our black blood T1 weighted post-contrast imaging, and this just gives us a higher spatial resolution assessment. And other useful sequences are our post-contrast non-gated volumetric fat-suppressed T1 weighted gradient echo sequence. Similar to CT, this just enables us to reconstruct the images in any plane. In this case, we can see that we've reconstructed along the line of the SVC and the right atrium, and we have a mass that's actually narrowing the cavo-atrial junction. We can do more delayed imaging, so our standard, what we would use for a viability assessment, so delayed inversion recovery imaging, about 10 minutes post-contrast. And in this example, we can see a small filling defect in the left atrium, which is not enhancing at all. So this is an example of a thrombus. And finally, a useful supplementary sequence is tagging. So here we're laying down grid tags over the image of interest, and it helps us to assess the relationship of the mass to the myocardium. In this case, this mass is quite close to the right side of the heart. We can see that there's no deformation of the grid tags within the mass, indicating that separate to the myocardium. This represents a teratoma. Just a few troubleshooting tips. Obviously, it's important for any radiology study to have access to the prior images. For MR particularly, it's important to review those prior studies to ensure that we're covering the mass appropriately and getting the most efficient scan possible. We need to be aware of the limitations of each technique, so we might miss small or mobile masses due to spatial or temporal resolution issues. With regards to arrhythmias, for CT, we can use rate control, so give the patient beta blockers to slow the heart rate down. If there's a problem with ectopics and we've done a retrospectively gated scan, we can edit our ECG to some extent. And with MRI, we have some tricks that we can use, including arrhythmia rejection and real-time imaging. Again, if the patient's unwell, consider CT as your next test, or with MR, there are fast sequences we can use, including single-shot imaging and real-time imaging. So we've talked a little bit about technique. Let's move now to interpretation. So we really have to know our cardiac anatomy to determine if we're dealing with a mass. There are a number of normal variants and embryologic remnants that can masquerade as a mass, particularly on echocardiography. And we'll just take a look at some of these. So this is a young lady who presented with suspected masses that were seen at her transthoracic echocardiogram. So this is just a still image from an apical four-chamber view. We can see a couple of echogenic lesions associated with the right atrium. And on the MRI, if we look at the T1 weighted image first, that more anterior lesion has T1 hyperintensity, and within it we can see a central focus of a flow void, and that is the right coronary artery. The more posterior lesion is associated with the wall of the right atrium. It's similar to myocardium in signal. And if we look at the still frame from the cine image, the bright blood image as well, we can see a similar appearance. So here are two pseudomasses, AV groove fat, that more anterior mass, and the crista terminalis, which is that fibromuscular ridge that separates the rough from the smooth parts of the right atrium. And other normal variants we might see include the eustachian ridge separating the coronary sinus from the IVC, moderator band within the right ventricle. Any ventricular trabeculation, in fact, can mimic a mass, as can pectinate muscles within the atrial appendages. So moving now to non-neoplastic masses. So once we've confirmed that we are actually dealing with a mass, there are several questions we want to ask. Firstly, if there's any relevant clinical history that can help us make the diagnosis. For example, if there's any history of atrial fibrillation or a primary malignancy. We want to look at the characteristics of the mass, so evaluate its location, whether we're dealing with an intramural lesion, an intracavitary lesion, a valvular mass, or a pericardiac mass. We want to take a look at the attachment of the mass, whether it's broad or narrow, and the margins of the mass, whether it's well circumscribed or infiltrative. The mobility we want to assess, and also the involvement of adjacent cardiac structures and impact on heart function. And then we want to take a look at tissue characteristics, so CT density, MR signal, and enhancement characteristics. And based on these, we can answer the following questions. So whether we're dealing with a non-neoplastic mass or a neoplasm, and if the latter, whether it's benign or malignant. We can also answer the question of whether surgery is going to be needed. So often we are still going to need surgery to make the diagnosis, or it may be necessary for either curative or palliative treatment, and imaging can help to guide the best approach. So here's a list of pseudotumours, quite a long and extensive list. We can divide them by location or their tissue characteristics. Of these, the most common is the thrombus, and we'll take a look at some of the more common and distinctive ones here. So this is an elderly female, this is a non-contrast CT, and we can see an abnormal appearance to the interatrial septum. It kind of has a lobulated appearance, low density, which is essentially fat density. And this is the classic appearance of lipomatous hypertrophy of the interatrial septum. At MR, we see a similar appearance, or what we would expect to see. So on T1 weighted imaging, bright signal consistent with fat, and we can confirm this by using a fat suppression sequence to see if the fat actually cancels out. So this represents unencapsulated mature adipose tissue. It resembles brown fat. It has this classic dumbbell configuration, sparing the fossa ovalis. We can see it's pretty common. It occurs in older patients and more obese patients, and it's usually an incidental finding and something that we want to leave alone. Very occasionally, it has been associated with right atrial obstruction and arrhythmias. Moving to thrombus, that most common of the pseudotumours. So this is found at sites of slow flow, so particularly in the left atrial appendage for patients with atrial fibrillation, or in patients who've had prior MI, we tend to see it at the left ventricular apex. And density or signal of the thrombus will be variable depending on the age of it. And the characteristic finding is no enhancement whatsoever. So it can be quite difficult at both echo and CT to make that determination and differentiate a thrombus from a neoplasm, and MR is really the way to make the definitive diagnosis here. Our post-contrast images are the most important. So for thrombus imaging, an early gadolinium-enhanced sequence has been advocated. So it's essentially doing your late gadolinium scan, but 2 minutes post-contrast. And we use a longer inversion time of 400 to 500 milliseconds. Or alternatively, at 10 minutes post-contrast, again, we can use a longer inversion time of 600 to 800 milliseconds. This is at 1.5T, where we expect to see no enhancement whatsoever within the thrombus. So here's a different case, a 72-year-old. He presented with abdominal pain, and this is one of the top slices from his abdominal CT. We can see an abnormal appearance to the lateral wall of his left ventricle. There's some outpouching here, there's a focal bit of calcification, there's crescentic low density. And this is just an example of a pseudoaneurysm, so a kind of mass that we don't want to biopsy. And at MR, this is the appearance. So what this represents is focal contained rupture of the myocardium. It's most commonly due to myocardial infarction. It's most commonly found along the inferior wall as opposed to the apex, which is what we see with true myocardial aneurysms. And the wall of a pseudoaneurysm actually represents scarred pericardium, so we would expect to see no overlying epicardial fat. Pseudoaneurysms are characterized by their narrow neck, and post-contrasted MRI, we do see a lot of late gadolinium enhancement of the wall of the pseudoaneurysm. These can rupture either acutely or if it's a large pseudoaneurysm. So other vascular lesions that we can come across that can certainly mimic a neoplasm, coronary artery aneurysm. So this is an example of a right coronary artery aneurysm in the atrioventricular groove. On the coronal oblique cine images, we can see the same appearance, this aneurysm here, in line with the proximal and mid right coronary artery. And another example here, we can see an abnormal mass, which has some flow turbulence within it. But interestingly, we can see that the right coronary artery is actually separate to this mass, and the MRA in this case was very helpful. So we saw an example of this earlier on CT. This patient has had aortocoronary bypass graft, and this represents a bypass graft aneurysm. A different case that we saw recently was an elderly patient. She presented with exertional symptoms. On her initial transthoracic echo, we can see an abnormal mass. So on this parasternal long axis or three-chamber view, we can see an echogenic mass, which is in close proximity to the left atrium, the mitral valve, and the aortic root. On the oblique short axis view, and this is really targeting the mitral valve, we see a similar appearance, a very echogenic lesion, and here we can appreciate some posterior acoustic shadowing, indicating calcification. CT gives us a more comprehensive assessment. So here on post-contrast images, we can see a similar appearance, so a very hyperdense mass. We can see some peripheral calcification. On our three-chamber view, it looks as if it's actually encircling the mitral valve. And the pre-contrast imaging in this case is very helpful to confirm the lack of enhancement. So this is an example of caseous mitral annular calcification, and this is one variant of mitral annular calcification which we see very commonly. It's simply a degenerative process. What's interesting about the caseous MAC is it is representing liquefactive caseation necrosis. It is not TB related, it is not infection related. Classically, we'll see it between the posterior mitral valve leaflet, the posterior annulus, and the wall of the left ventricle. And as occurred with this patient, it can impinge on left ventricular inflow or outflow and become symptomatic. So the classic finding is this peripheral calcified rim, which is best appreciated on CT. At MR, we'll see variable appearances within the mass due to variable content, but a classic finding is rim enhancement or late gadolinium enhanced images. So finally, let's take a look at some of the neoplastic masses. And this is an important slide to remember. So basically here we're just looking at features that help us determine between benign and malignant tumours. For a benign mass, we're looking for homogeneity of the mass, with some exceptions. Well circumscribed mass, these masses tend to occur in the left heart. They're often intraluminal and have a narrow attachment to the myocardium or the valve, and they tend to be solitary with variable enhancement. On the other hand, malignant lesions are more likely to be inhomogeneous, they are more infiltrative, they can involve more than one chamber, and they like the right heart better than the left. They tend to have a more broad attachment, they can be multiple, and they're usually large at diagnosis. If we see a hemorrhagic pericardial or pleural effusion, that's an indication we're dealing with something malignant, and again, they can display variable enhancement depending on their histology. So let's take a look at those primary cardiac tumours. Just as a reminder, they're pretty rare. Most of them are benign and occur in adults. The most common of these are myxoma, papillary fibroelastoma, and we'll take a look at some of these. Malignant lesions, again, rarer still. The most common of these is the angiosarcoma. So we'll take a look at some of the benign lesions to begin with. So this is a mass within the left atrium. It's pedunculated. It's attached to the interatrial septum, very well circumscribed, but does have some heterogeneity within it. And this is the classic appearance of the myxoma. So this accounts for up to half of primary tumours. It's most commonly found in middle-aged females. It's usually a solitary finding, but can be part of the Carney complex. Patients present with constitutional symptoms or complications such as embolic phenomena causing stroke or obstructive symptoms, and these can also recur after resection, particularly in the familial situation. Imaging-wise, most of them are found in the left atrium, as we see in our examples here. They're usually attached to the interatrial septum and intracavitary lesions. They're very heterogeneous, as they can have myxoid, cystic, fibrous, osseous components or hemorrhage. And they do demonstrate enhancement. At MR, they're fairly iso-intense on T1 weighted imaging and hyperintense on T2 weighted imaging. So here's another lesion that came to light at echo. So this patient had a low-grade fever, some shortness of breath. This is sort of a non-standard view looking at the tricuspid valve, in fact. This is the right ventricle here. And we can see this mass that's moving with the tricuspid valve. It's quite round, and it looks as if it has some papillary margins. So the question in a patient with a low-grade fever is whether we're dealing with a vegetation or whether this represents a neoplasm. So this patient also went on to MRI, and here on the late gadolinium-enhanced images we can see homogeneous enhancement of the mass, and this was a papillary fibroelastoma that was confirmed at surgery. So these interesting tumours are composed of papillary fronds with the fibrocollagenous central stalk. They're one of the more common primary tumours that we see, and they're usually asymptomatic, but again, patients can present with a stroke or chest pain. They're usually valvular, and they tend to like the left heart valve, so the aortic and mitral valves more so than the right, and they're usually small at diagnosis. So at CT they look hypodense, at MR they're fairly T1 iso-intense, they can be a little bit hyperintense on T2 weighted imaging, and they do demonstrate delayed enhancement. Lipoma is a pretty easy mass to recognise, so usually occurs in younger patients than lipomatous hypertrophy. We'll see a well-encapsulated lesion which has pure fat density or signal. Fibromas, these are usually seen in children. They're usually incidental and have gradual growth, but they can present with arrhythmias or compressive symptoms, and hence surgery is recommended for these. So they're usually found within the left ventricle. They're usually fairly homogeneous, so T1 and T2 hypointense, and they demonstrate homogeneous late gadolinium enhancement, and dystrophic calcification can be seen, which is better evaluated with CT. Rhabdomyoma, another childhood tumour. So this is associated with tuberous sclerosis, and these are usually treated conservatively. In terms of imaging, they're interesting in that they can be multiple, so that breaks that rule of benign lesions in general, but they are found within the left heart, usually the left ventricle. They're hypodense on CT, and at MR, T1 iso-intense and T2 hyperintense. It's an interesting lesion that came to light on catheter angiography. So this patient had a known history of coronary artery disease, and obviously they were concerned about coronary artery stenosis. But if we look at this image from, or this video from a catheter angiogram injecting the left coronary system, we can see this abnormal mass here at the top of the screen. This first appears during the arterial phase, and it persists through into the venous phase, and we'll just see it coming through again shortly. Fairly well circumscribed. So because of this, the patient was also referred on to MR, and here we can confirm the presence of a mass, which is fairly iso-intense on T1 weighted imaging, hyperintense on T2 weighted imaging, and it does demonstrate some enhancement. The first pass perfusion imaging shows a similar appearance to the catheter angiogram. So here is the mass, and as we cycle through again, we can see that this enhances pretty early in the arterial phase with persistent enhancement. So there was concern about malignancy, and the patient was referred for a PET-CT scan, and here we can see increased metabolic activity, but not a huge amount of increased metabolic activity. And there was still a question about whether this was a malignant or a benign lesion, and so this lesion ended up being resected, and this was a paraganglioma. So this is a pretty rare tumour. It's a sympathetic nervous system tumour. It's found along the sites of the sympathetic ganglia, so that's the atrioventricular groove and the origins of the great vessels. And imaging features, as we saw in this case, can be indeterminate. And these are difficult to resect because of their vascularity and also because of their location. So we'll just finish with a quick discussion of some malignant tumours, beginning with the angiosarcoma. So this is a tumour of endothelial cells. It's the most common sarcoma and the most common primary malignancy we'll see. It's usually found in middle-aged males, and these are bulky tumours. They cause obstructive symptoms. They're usually centred on the right atrium, and most of them have metastasised at the time of diagnosis. They have a pretty wild imaging appearance, so they can be irregular, nodular, contain hemorrhage and necrosis, and pericardial involvement is common. They enhance avidly, and an MR finding, if they are vascular enough, is that we'll see flow voids within them. So other sarcomas, which are rare, have a more variable appearance and location. Interestingly, some of these, like the left atrium, particularly the undifferentiated sarcoma, which is the second most common of the sarcomas. Next is primary cardiac lymphoma. So this is lymphoma that's confined to the heart or mediastinum or heart or pericardium, much less common than secondary lymphoma. It's usually an aggressive B-cell tumour that is found in immunocompromised patients, and it has a poor prognosis. It's not treated surgically, but with chemotherapy. Similar to the angiosarcoma, we might see a nodular mass, particularly within the right atrium. We can get diffuse infiltration of the pericardium, leading to a large effusion and potentially tamponade. At CT, they're hypo or isodense, and they demonstrate heterogeneous enhancement. At MR, they're fairly isointense to myocardium, and they tend to demonstrate low-level enhancement. And last but certainly not least are metastases. So again, these are much more common than primary cardiac neoplasms. The most common primaries that will metastasize to the heart are the lung, breast, melanoma and lymphoma. We're obviously going to suspect this if we know the patient has a primary cancer, and cardiac metastases are usually a late finding, so there are usually going to be metastases elsewhere by the time we make this diagnosis. These, like the pericardium, more so than the myocardium, particularly lung and breast tumours. And there's a few ways for metastases to reach the heart. So direct invasion from the lung, breast or esophagus, transvenous extension where the tumour's grown via the veins into the heart, and that's the mode for hepatocellular carcinoma and renal cell carcinoma, hematogenous spread, which is preferred by melanoma, lymphoma and leukemia, and finally lymphatic spread. So here's a 4-chamber view, bright blood CNA imaging from an MR showing a mass within the right atrium. And we can see it's bobbing around a little bit. It looks as if it's not completely freely moving, but we don't see an attachment on this view. And this case just highlights the importance of orthogonal views, particularly for MR, where we don't get that full volumetric assessment. So here we can see, in fact, that this mass is extending up into the heart from the IVC. And what we were seeing on the previous scan was just the tip of the iceberg. So on first pass perfusion imaging, we just keep an eye on the mass, and we can see that it does enhance during this first pass perfusion run, so that excludes any bland thrombus. We're dealing with tumour thrombus here, and this was a patient with hepatocellular carcinoma. Breast metastases, fairly typical appearance, so we see a couple of myocardial masses with pericardial involvement. We can also appreciate an associated pulmonary metastasis. One final metastasis that we want to discuss a little bit separately is melanoma. So most METs tend to be T1 hypointense and T2 hyperintense, but similar to melanoma metastases elsewhere, due to the presence of melanin, we can have T1 hyperintensity, and that's what we see here in this exophytic mass that's associated with the anterior wall of the left ventricle. So that was a very quick run through quite a few masses. Hopefully I've shown you that mass workup, it does benefit from having a multimodality assessment. We need to be able to recognise anatomic variants and lesions that we should leave alone. The most common cardiac mass that we'll see in clinical practice is the thrombus. The most common cardiac tumour that we'll see is metastasis. Much less commonly, the most common primary tumour we'll encounter is the myxoma, and rarer still, the most common primary malignancy is the angiosarcoma. And despite all the rules that I've shown you in the various cases, still, in many cases, we're still going to need a tissue to make a definitive diagnosis. With that, I'd like to thank you very much and acknowledge the following people. So that brings this session to a close. All the speakers are up the front, so if you have any questions, please feel free to come up and speak to us. Thank you for your attendance.